We now are wondering how should we target these patients, and the available armamentarium of possible therapies is covered by Shelley Zieroth. Shelley, over to you.
Thank you so much. I'm going to be talking about the available armamentarium for the treatment of worsening heart failure. And I think, we have some options for sure. So I was very pleased to be part of this JACC Review Topic of the Week, where we tackled nomenclature, which Erasmus was speaking about, epidemiology, and future directions. And it's interesting that there likely is some overlap between worsening heart failure and acute heart failure, with acute heart failure being the hospitalized phase along the worsening heart failure spectrum. But certainly the definition seems to be a little bit in flux. And even there's been a lot of discussions as well about strong HF during this meeting as well. So perhaps we'll have an opportunity to talk about that and the use of natriuretic peptides for defining a worsening heart failure episode. So in our review paper, we mentioned, we have Table 1 here, which is really the evidence-based armamentarium. The newer ESC HFA document actually, so we have 4 papers that we highlight for the treatment of worsening heart failure. 5, 6. We mentioned 6. We highlight 6 studies, and I'm going to go over those in more detail. The recent HFA document actually expands upon that and includes 18 papers which they feature, and in part because some of those include recent worsening heart failure post hoc analysis from larger studies which weren't particularly designed to investigate the worsening heart failure patient population. So I think you should stick with this one, 6 simple steps, and we'll start looking at those a little bit here now. So first of all, I'm going to tackle Pioneer. Pioneer HF was inpatient initiation of sacubitril/valsartan, and we saw in those patients who were randomized to sacubitril/valsartan in hospital, it met its surrogate primary endpoint of a reduction in NT-proBNP. Here I show you a post hoc analysis looking at a reduction in cardiovascular death or heart failure rehospitalization versus enalapril, a 42% relative risk reduction. And I submitted this slide deck before yesterday's late-breaking clinical trials. We can now expand upon that with Paraglide HF as well. We can expand from the HFrEF patient population to the HFpEF patient population. We also saw a 15% relative risk reduction in NT-proBNP in hospitalized patients or those with a recent worsening heart failure event. And we also saw that there was some heterogeneity in terms of treatment benefit. In those patients who had a reduced ejection fraction of less than 60%, we saw even more benefit for sacubitril/valsartan, so those with less than normal ejection fraction. Of course, the AFFIRM acute heart failure trial demonstrated that administration of ferric carboxymaltose to patients who had identified iron deficiency. They received their first dose prior to discharge from hospital, and treatment was safe, reduced the risk of heart failure hospitalization, and improved functional capacity and exercise tolerance in patients with a recent worsening heart failure event. MPulse, another study which enrolled patients in hospital regardless of ejection fraction. Some of them were de novo heart failure as well, and patients who were treated with empagliflozin versus standard of care therapy during this hospitalization were 36% more likely to experience a clinical benefit than those who received placebo. And you can see the wins in the purple here for empagliflozin pretty much across the board. Omecamtiv mecarbil. Omecamtiv mecarbil increases the number of independent force generators, and it's really like more hands pulling on the myosin and actin rope. I actually likened this to me trying to get my boots off at the end of the day yesterday after the conference. And so this is a newer agent, has not been approved in the U.S. At this time, but the Galactic HF trial included patients with a recent worsening heart failure event in the last year, and we saw a 8% relative risk reduction in the composite endpoint of first heart failure event or cardiovascular death. This was a statistically significant result as well. And then we have vericiguat. This is an agent which stimulates soluble guanylate cyclase to increase cyclic GMP production, and that results in significant hemodynamic benefits for a patient with heart failure presentation. There is vasodilatation. There are additional anti-proliferative effects and anti-fibrotic effects, as well as anti-inflammatory effects. And I'm happy to say that this was recently approved in Canada a couple of weeks ago. So I'm very much looking forward to adding this to my toolbox for patients with a recent worsening heart failure event. The Victoria trial enrolled patients who had had a worsening heart failure event within the last 6 months. And the clinical trial enrolled patients with an ejection fraction less than 45% with symptomatic heart failure. Think about your heart function clinic and how many patients that might actually involve. The study showed a 10% relative risk reduction. It was statistically significant for those patients who were randomized to vericiguat on top of standard of care. And the median treatment duration for the primary endpoint was actually shorter than what we had seen for any outpatient ambulatory clinical trials at 10.8 months. This is, as I'll show you on the next slide, is because this was a much sicker patient population. The annual number needed to treat was 24, an absolute event reduction of 4.2 per 100 patient years. So let's put Victoria in context with our more contemporary clinical trials for heart failure. You can see some of the SGLT2 inhibitor clinical trials on the left-hand side, DAPA-HF, Emperor reduced. And because Victoria selected a patient population who'd had a recent worsening heart failure event, they were at increased risk of having another event in the near future. So if you look at the median follow-up for Victoria was substantially shorter than any of the other outpatient ambulatory clinical HFrEF trials that we had seen. I want you to look at the primary endpoint row. Let's see here. I can use my pointer here. There we go. I want you to look right there. This is the placebo group for the Victoria trial. And you can see that the comparator group had one of the highest event rates that we had seen in an outpatient ambulatory clinical trial, but that was significantly reduced in those patients who received vericiguat in the trial. So event-driven trial, sicker patient population, higher NT-proBNPs, an ejection fraction of 29%, as well as what we were seeing. And Victoria has really changed the way that I'm going to approach my patients in clinic. I'm going to look at, are they on the 4 foundational therapies? That's checkbox number 1. Checkbox number 2, have I looked at them for device referrals and device optimization? And checkbox number 3 for every patient now is going to be, have they had a worsening heart failure event? And do I have an opportunity now to reduce the residual risk on top of the foundational therapies as well? This is the HFA worsening chronic heart failure recent paper as well. Harasimos, you're on here. Stefan, you're probably on here too somewhere. A large author panel for sure. And I just want to highlight this figure. Again, we have to focus on the treatment and prevention of worsening heart failure, thus my check boxes. So for prevention, for foundational therapies, and then are they eligible for vericiguat to reduce the residual risk more? So important that we recognize that we can use vericiguat as well, not just in your outpatient heart function clinic, In the Victoria trial, 11% of patients were enrolled during a hospitalization as well. And here is a very novel concept as well, a recent paper by Steve Green focusing on hospital at home for worsening heart failure, even moving the needle even more upstream, and a very patient-centered approach where we manage patients with worsening heart failure at home, either through home-based interventions like IV diuretics, but again, recognizing an opportunity to reduce residual risk for those patients with a recent worsening heart failure event and considering all therapeutic options for them. And with that, I have completed my presentation, and I will hand it back to our chair.